Dr. Bande?
Yeah.
Yeah, we're ready with the ultrasound supraclavicular here.
Ultrasound carried supraclavicular. I sometimes stand on the other side of the patient. Normally you would have seen everybody standing at the head end. I am actually standing at the foot end of the patient. The patient's head is on that side, his foot is that side. It's just because it's a left-sided block. I'm right-handed, I tend to use my left hand for the probe, so I just stand on the opposite side. That's something of ergonomics which everybody has to sort out for themselves.
Yes, we can see.
Okay, and now if you can see that another thing which I tend to do with supraclavicular is there is a small sheet under the patient's shoulder that just gives me a bit more space to put my needle in if I'm doing it an inline approach. Otherwise, putting a needle in and actually directing it is difficult if you don't have any kind of support under the patient's shoulder. Most of them must have been showed in the clavicular fossa. Put the probe there. First thing you nicely see is a good pulsating artery. Can you see on the video screen?
Yes,
there?
yes, we can see.
It's a nice, good pulsating artery. All you have to do is, I tend to make sure that the artery is as round as possible. I don't keep it elliptical, I don't keep it this thing, I try and keep it as circular as possible with the nerve sitting right behind it in a bunch. See which approach is the best, and probably there you can probably see most of the nerves bunched up just behind the artery. Sometimes if you have a confusion on whether there's a vessel there or not, occasionally I put a color on and see if you just see a big structure just behind the artery, it can quite often be just the nerves together. There's only one pulsatile structure, there's nothing else there. I'm quite happy that it's just the artery there and nothing else, that's just the subclavian artery. Look at this structure there just behind. If you follow it, it's probably two roots joining together to form one nice big root. If you can just point it out on the screen. No, just yeah, that one. I'm just going to chase it up towards the neck. If you just see it, it actually splits into two. So it's two joining together. That's most likely the inferior trunk, which is joining together to form one nice big trunk. So the idea would be to block that whole area behind the subclavian artery. Awake patients, I prefer using a bit of local anesthetic if I do get some. And local usually at where I'm going to put my needle in, छोटा सा injection. The other reason I tend to use local nowadays here is because the needle which we are using today is actually a slightly blunt needle. It's when you're pushing it in, it is actually quite blunt. Can we flush the needle? I think if you see these are the sonoplex needles which are very blunt, the tips very blunt, and pushing it in is painful for the patient. But they have very good visibility under ultrasound. So we've been using these same needles and we're getting quite good results out of them. As usual, make sure your needle's patent, flush it to the tip, make sure it's free of any kind of air in it, because air is your biggest enemy. It actually obscures your vision. Even if you inject half a mil of air into the field, it obscures the vision completely. I've already given a bit of local. That gives us time for the local work. Just go at the posterior end of the probe, puncture a bit vertically, and then come in. So this is going to travel a little bit of a distance, but hopefully you see the whole needle coming in one go. Now, what I tend to do is do the posterior inferior bit of the artery first. So I would tend to go in a bit closer to the vessel. I felt a little bit of a pop that's gone into the sheath. He's not complaining yet of any kind of dysesthesia, and the needle tip is right at the back. I'll just position it a bit better.
Sorry to disturb you. Can you just, as you go on, can you just explain where is the first strip, where is the lung?
Okay.
And
yeah.
Just for the sake of everybody.
For the sake of everybody, I'll just hold there. If you can point out, we'll again go back to the artery. That's the artery. The vein is anterior to it. That's the vein. The nerve bundle is always posterior to it. That's the whole plexus there. the first strip is just under the artery. Quite often it's either the first strip or the pleura. What you have to do is ask the patient to take a nice deep breath, and then you'll be able to make out which is the pleura, which is the first strip. But quite often they look like a uniform single line. So you're looking at, that is probably what the pleura has come up now. You've got the dome of the pleura there, and just under the artery you've got the first rib there. Can somebody see a pulsation under the rib, margin of the rib? No. Can we point out there? No, just there. Just there. Can somebody see a pulsation there?
Yeah, we can appreciate.
And can you see a nice round vascular structure? Now I'm going to ask them to put the color on. Can you put the color on it? Can you see pulsations there?
Yes, okay.
This is something called, this is an artifact. This is something called a double barrel effect, which the subclavian artery actually shows because it sits on a rib, and it's because of the echogenicity of the two structures, it actually shows something called as a double barrel effect. Seen it quite often in the past. People keep asking me, can I record it and show? I think if this is getting recorded, that's what it is. It's a double barrel effect for the subclavian artery. Okay, take the color off them. Yeah. That's an artifact. So people learning ultrasound, beware, that is not an artery, that's actually an artifact. If I just change the angle of the probe, actually it will disappear completely. Some place it will be much better, some place it will disappear completely. So getting back to the block, I'll just trace my needle back. If you can see the needle's just sitting just behind the plexus. And all I'm going to do is try and advance the needle just to the corner of the artery, and now he is actually complaining of a bit of dysesthesia. Paresthesia is there, and so you're probably touching one of the nerve roots, and just touching the bottom nerve root. I'll just try and avoid it if we can, because you don't want to go through the nerve. You need to try and avoid it if you can. So I'm just going to go. अभी भी हो रहा दर्द? गर्दन में दर्द है क्या? या हाथ में? Where? In the neck. Okay, neck is all right. Neck is not an issue. Neck is all right. If it's the hand, I would be worried. So we've almost reached where I want. Where is that? Okay.
We can see the needle tip, isn't that a very right
the
position?
needle tip is almost there. I like to go a little bit closer to the artery and inject initially. I know some people say that you can have ulnar sparing with it, but I tend to do that. But we will go from here. We will inject just half a mil or a mil and see actually if we can aspirate and then inject half a mil and see if we can see it coming out. Now it's coming out, most of it is coming out posteriorly, that's fine. All I'll do is use that as a guide and then puncture underneath, and then that, now the needle is almost under the plexus. So aspirate and inject again. And if it's difficult, please let me know. Okay. Now if you can see, it's lifting off from the first strip. It's taken off from the artery. Now a lot of the drug, I would probably give about 5-6 mils there. Aspirate every few mils and then inject again. And then next thing I would do is actually go above it and then do a second injection. We're going to use about 20 mils for the whole block. Some people are going down to about 15 mils now. I still use about 20 mils. Don't like a half-hearted block.
Can you take the picture on the other side, other corner? Yeah, okay.
Yeah, okay. That's about that. Now I'm coming back with the needle. If you can see the needle coming back up. Now, this is where putting a pillow or something under the patient actually helps, because it gives me space to angulate the needle and go towards the top end. Because otherwise, angulating and going towards the top end of the plexus is a bit difficult. So that we've got a needle coming back towards the plexus. Yeah. Just flatten the needle and then we'll actually tend to reach it. Okay. Aspirate. Not negative. If it's negative, just inject a mil so that we know where we are. Now we are on the other side. We are actually getting a bit of local there. Just going to come back. Aspirate. Inject. It's on this side of the plexus. So if you can see, the bunch of nerves is right in the middle, and we injected almost 360 degrees around the whole plexus. we've used how much? We've used only about 15 mils till now. And I'll be quite confident that we've covered it. But for sake of completion, we are going to complete the whole thing and inject the whole amount. Just stop. Okay. Aspirate and inject again. There we go. That's almost every nerve covered along with local anesthetic. I think that's about 20 mils. That would be it, I think, for this block. Normally what we've injected is a mix of, it's a bupivacaine 0.375. Quite often tend to use only 0.375 and don't use 0.5 or higher concentrations, because 0.375 tends to work in about 5 minutes. It shouldn't take longer than that to work.
You went posteriorly in the beginning.
Yeah.
Isn't that too close to the pleural reflection there?
It is close to the pleural reflection, but that's the whole idea of using the ultrasound, that you actually decide where you want to inject in your, it's on top of the first rib. If you, here on the ultrasound you see that it's actually quite close. When people do it blind, you go and hit the first rib and inject next to it, and you do not know that you're actually next to the pleura. Here I knew the needle was on the first rib. I actually felt it on the first rib when we started the first injection. So you have to combine both things. You have to think that you are actually not only under ultrasound, you're doing a blind technique also. You actually would go and hit the first rib before you start doing any injections.
By chance, if you puncture the pleura, any ultrasound indication comes or any technical point which you like us to remember?
What I always tend to do, and if I'm doing it under ultrasound guided blocks, I have to see the local anesthetic spread in front of my needle. That's almost diagnostic that actually it's going in the right place. If you can't see your local anesthetic spread in front of your needle point, then you're either going into some structure which can accommodate it, or you're intravascular, so you're not in the right place. So you need to make sure that your local anesthetic is visible, and that's the big advantage ultrasound gives over any other kind of nerve stimulator or a blind procedure. You can actually see a local anesthetic spread.
Is it always in plane, or you can do it otherwise?
You can do it out of plane as well. Quite often if you're putting a catheter, it's easier doing it out of plane. As you keep doing it, it's easier doing it out of plane if you're putting a catheter, because the catheter tends to go in much more easily. The same block, if you do it out of plane, your needle will probably be, depending on how you want to go it will probably be coming from the neck, from the top. And that would actually let the catheter go down towards the intraclavicular area. So you can do it out of plane quite comfortably. But remember, out of plane is always, needle tip is always a bit of a problem. You do not know where the needle tip is. And unless and until you're confident with your probe and your positioning, I would probably say it's something which is not recommended for beginners. It probably is something which is recommended for people who have done quite a few blocks and they are quite happy with their needling positions.
Okay, thank you. Any questions from the audience?
If you puncture an artery. I've just been asked a question, if I puncture the artery, what happens? Now, yes, you can accidentally puncture the artery. If you puncture it, the best thing is to put pressure and then weight on it. There's no other way. That's all you do. The idea of, if there is no hematoma, you can restart. There's no reason why you can't restart if there is no hematoma. Obviously, if there's hematoma, your anatomy gets distorted, then you can't do any injections.
Any other precautionary measures while doing this? Any tips you want to convey to the audience?
As I said, couple of things. One is, because the direction of the needle is such that it comes from behind, I find it useful to keep shoulder bag just under the same operating side shoulder. If you see, he's got a small sheet, couple of sheets, just to lift it off so that I have space for my needle and I can actually lever my needle there properly.
Okay.
Other than that, be just careful, make sure you see the needle tip all times. The basic precautions with any ultrasound block.
Okay, thank you very much. I think it was excellently demonstrated.
Have you ever come across any complication when you have done a continuous catheterization for supraclavicular?
I have to be honest, the number of catheters I put for supraclaviculars are very limited. Yes, the commonest problem actually is that there is a pericatheter leak and you don't know what to do with it because half the drug comes out of the catheter site. That seems to be more common in my practice than actual major complications. Because most of them are well looked after post-operatively. So main issue is always the pericatheter leak, which is, and it spoils the dressing, it lifts off the dressing and then your catheter moves that's a bigger problem for me than anything else.
What's the reason exactly why that leak is there? Can you insert it more length and get away with it, or it is not possible?
No, you have to remember that the needle you use for your through the needle techniques are actually quite big. So you're looking at much bigger needles to do the procedure. So that might be one of the reasons why it does happen. But a lot of people tend to use glue. You have these plastic surgeons use this glue. They tend to use the glue around the catheter tips, catheter where the catheter goes in. So that tends to stop leaks. But you have to remember each glue is about 1,500 rupees. So it's difficult for us to use that glue frequently.
Thank you very much. I think next case is ready there.